So I'd like to say thank you so much to Braun and Carrie for inviting me here today. And following those two amazing talks by both Karen and Haidee, they're really amazing. So I'm delighted. So those of you who don't know me, my name is Cara Dunne. I work as a gastroenterologist in St James's Hospital in Crumlin. I have a special interest in patients with intestinal failure. And I'm going to sort of talk a little bit about what happens to patients on their discharge and that multidisciplinary approach that we have when they're at home, mainly on their PN, and how we should follow them, and the things that we do well and probably the things that we're probably not doing very well, just because we don't have that whole MDT, as Karen was saying, to be able to manage these patients in a really, really aggressive way when they're discharged home. And our goal is always to have these patients continue to do well. We don't want complications. We don't want to refer them to Haidee and the team in Southampton or St Mark's because they've run into trouble. What we want is these patients to have a good quality of life, to have some form of independence, and to live well on their TPN. And the majority of them can do that very well. But it does take a little bit of thought about how we manage them long term. So some of the young people that I've transitioned over from Crumlin would be, 26. I have one who's the oldest living pediatric patient on TPN, so she's 26 years of age now. So I'm dreading the idea of pregnancy, actually. That's actually quite horrifying. So a little bit on the way of introduction, we're really just going to talk about PN, the challenges of transitioning the patients from the hospital to the home, and that multidisciplinary approach that we need, and how to explore the roles of how the healthcare can sort of manage these patients in the continuum of the care. So I thought we might go back a little bit and talk about intestinal failure, the definition and the pathophysiology, because a lot of the complications that we have, sometimes we attribute to, and a lot of it is due to them being on parenteral nutrition and the massive, usually surgery that they've had, but their underlying pathophysiology of what drove them to end up having TPN also plays an important role in the type of complications you're going to see. So if you've got a Crohn's patient or an IBD patient, they will have been exposed down the years to corticosteroids and biologics. It does make them at much higher risk of metabolic bone disease. You may have a patient with radiation enteritis, so they may have issues with their gut microbiome, so you get a lot of gut permeability, so you're going to have a lot of risk of infections and things like that. So I think it's important to remember that it's not just about the TPN, it's about what brought them to the TPN. And it's always worth thinking about the physiological consequences as well. As Karen said, we are dictated by what we have, and that doesn't change. And, what we have and what small bowel we have will determine what type of TPN the person's going to be on and how much you can push their adaptation. Now, we do have other drugs that are available that might help that and push that a little bit further along. So this is really the ESPEN definition of a chronic PN patient. So it's somebody who's got prolonged inability to manage their nutrition from an enteral point of view. And we all see the type 1s in the hospitals, the post-surgeries. They usually evolve quite well, and then you move on to the type 2s that may be a little bit metabolically unstable, as Karen's patient was in ICU while they were stabilizing, and then they move on to the chronic, which is the type 3. So the pathophysiology is important, and I think it's important to think about why and how somebody has ended up in TPN and remember what it is. Now, some patients may have all of these as their pathophysiology. So you could easily have a Crohn's patient who has intestinal dysmotility because they have multiple small bowel resections. They may have internal fistula. They may have a small bowel to small bowel fistula. They may have stricturing disease, fibrosis causing subacute obstruction, and they may still have disease that's very active, uncontrolled, despite all the biologics that we have. Now, thankfully, those kind of patients are rare, but they are still about, and that phenotype is still around, and we're not really very good at knowing and understanding why some people will respond very well to some biologics and why some people will burn through them very quickly. So I think it's important because those patients will have different underlying conditions that will predispose them to complications such as intestinal failure related liver disease and metabolic disorders, especially metabolic bone disorders, and also lead to a higher risk of catheter related complications, which is really the big ones that we're worrying about. So this is just, I know that all of you know this is just sort of like about the intestinal fluid flux. I think it's just important to think about how much fluid we actually make just by walking around and doing nothing at all, not even eating, not even thinking about it. And I always will say this to patients, when we're talking about hypertonic solutions, we're talking about St. Mark's, we're talking about diurolite, trying to explain to them, the volume of fluid that you make alone from just your saliva and your stomach is over 2 litres. And then when you add in your pancreas and you add in your liver, making all of those good juices, you've got another litre, and then you've got your small bowel as well. So by the time anything hits your colon, you've got about 7 or 8 litres of fluid that you need to absorb. So that's how hardworking the colon is. Everybody dismisses the colon, but I love the colon. It's really, really underused. And I'm a big, big advocate of trying to push for distal feeding, even if you have access just to give the St. Mark's down there or the diurolite down there. It'll make a huge difference, because as you'll see, there are huge physiological consequences of fast transit. And what happens is, if you stimulate your colon and if you distally feed the colon, what happens is you get kind of a feedback mechanism which will tell everywhere else, even if you're not in continuity, it will tell everything else, like your stomach and your small bowel, to slow down. So there are reasons why we end up having this fast transit, and one of the big reasons, as Karen and Haidee alluded to, is that the small bowel does not like certain concentrations of fluid, and it likes certain concentrations of sodium, being 90 millimoles, and that's why we ask them to take St. Mark's and double strength diurolite. Now, there are new things that we've been using to try and advising our patients. Ciara, who's here, will probably talk a little bit. We'll talk to you about it at the break. There's these things called AirNup that all young people have, which is like these bottles you can put in, and you can put a little top on it, and it makes something taste like Coca-Cola or 7-Up or something like that. So some patients that really are struggling that much, and it's only young people told me about it, that if they're struggling that much with tasting it, remember, your taste is not your mouth, your taste is your nose. So you can trick yourself into thinking that you're taking something else. So we use all of these kind of ways to try and explore and try and explain to patients why, and to explain to other doctors as well, because they will get mixed messages. So when these patients, sometimes they'll have renal complications, they'll go and see the renal doctors and they will just tell them drink more fluid. That's not what we want them to see. We do not want them drinking more fluid. We want them drinking the right kind of fluid, but we don't want them just drinking any random fluid. And there's this kind of disconnect. So it's always this way of educating and talking about it and reminding people, if you think about it back to first sort of principles, what are the physiological consequences? What are you trying to stop? What are you trying to prevent because you don't have a colon, or you don't have a lot of small bowel, or you have a little bit of liver disease or pancreatic insufficiency? So what are you trying to prevent? And that sort of helps you a little bit to understand why the physiological consequences are. And this is really essentially, the 3 types that we see. We've got their end-jejunostomy, we've got an end-jejunostomy with the colon, maybe with IC valve or colon intact. And then we've got kind of the best kind, which is the type 3, which is the ileocolonic anastomosis, ideally with an ileocecal valve and a cecum attached. Because what does that do? And these studies haven't changed that much. And you can see, I don't know whether it projects all that well, but as Karen said, you'll know that if you've got less than 50 centimetres of small bowel, not attached to colon, and no access to colon, that your chances of remaining on PN after 5 years are still very, very high. And with that comes all the consequences of having an ultra short bowel. If you add in a bit of colon, even if it isn't an ileocecal valve and a cecum, maybe it's only transverse colon, or it might be a bit of descending colon, you do reduce your the volume of PN that you will be on, and the number of nights you will be on, and your chances of getting off PN are much higher. And then again, if you've got ileocecal valve, your chances are much, much higher in anastomosis, and you've got ileum, chances are much, much higher of coming off TPN. Though that hasn't changed. That's physiology. That doesn't change. So it's what we do to try and force that in the intestinal adaptation and rehabilitation that helps that along the way. So again, Karen and Haidee have probably gone through this in much more detail, and I won't go through what we really do in hospitals because they've done that expertly and beautifully already today. So we've got your immediate, what you want to do is you want to get them stable, and then you've got to push the early phase of adaptation, and then your late phase with your maintenance of stability, and looking at what you can take. And you have to be sensible what they can take. Like Karen said, she's quite restricted with that lady with only 20 centimetres of small bowel. She's not going to be able to take oral nutritional supplements to get her off nights. but she is going to eat for comfort. So you have to be really cautious about, you know, what you can do and sensible what the kind of feed you can do. So we do have quite a few therapeutic options. We have to be really strict with our fluid. We have to watch for adaptation and try and push it all the time. Medical management, we've got the anti-diarrheals, anti-motilities. We have GLP-2, which is the new tetraglutide. Now, the caveat with that is that patients really do need to be stable, and as an outpatient for that, they can't really be an inpatient for that. If you look, Leuven is who we sort of link in with most, the Leuven intestinal failure unit there, with Tim Van Hussel. So they've had the most experience of it, and the team in France as well. And they would even suggest that if somebody is even had 60 centimeters of small bowel and they weren't in continuity, they would push for continuity, and then they would wait at least 18 months before starting the tetraglutide because they want to push adaptation. I debate that a little bit because I think you should use the GLP-2 to force adaptation. But anyway, that's, so I think, we've got something that we can use to force a gut to adapt quickly. And I just think that maybe waiting that length of time and the risk, and it's all about risk and benefit, really. There's no right answer to it. And then, as been discussed before, there's continuity surgery, bowel lengthening surgery, there's transplant as well. Transplant isn't without its risks and its complications. The numbers are much better than they used to be, and I think there's the 5-year survival rate of a small bowel transplant alone, and you will get a small bowel and a colon, would probably be about 75 to 80%, I think, Haidee. I think it dropped a little bit, but then it's a little bit better. But when you start having to add in things like a liver, if they've got cirrhosis, your 5-year survival rate is going to drop down. So our goal is we've got to keep these patients well, and we've got to keep them stable. So we can avoid giving them a transplant, but if they do have to have a transplant, that everything's there that needs to be there. So this is my little plug for the distal feeding. I always get really upset when the surgeons don't give me mucus fistula. Like, when you go back in and they're like, no. Well, you don't give me like a double barrel lumen. Anyway, they always say. So sometimes I'm lucky and I do, and sometimes I don't. But when I do try distal lymph feeding, even if, because I do think that it has a huge benefit upstream as well. You're also feeding the colon. You've got all those positive feedback mechanisms to your high output stoma. And then also you're adapting your colon, so when you put it back in continuity, it's not as much of a pressure, and it adapts much, much quicker, and the person gets out of hospital much faster. So this was the old distal feeding unit. Some people might remember it used to be on the wards. I think they were made in France. It was like a dialysis machine, and you'd have to sieve the stoma effluent and then put it through this kind of fancy pants machine. And even I think some of them are still around in the UK, but like you can't even get the parts for them anymore. But there's a new device from New Zealand called Chymerine Fusion device, and it's beautiful. I mean, I don't know why anyone didn't think about it sooner. And it's a one-stop shop, so the whole thing stays in the stoma bag. You've got a pump and you've got a distal feeding tube that goes down. So this is really only useful if you've got 2 stomas in the one site, or you've got a double lumen stoma where you've got access to your proximal and distal limb. And we have one patient on this. He's got really bad severe Crohn's disease, and it made a remarkable difference to his TPN fluid regime. So he went from needing 7 nights of TPN down to 3 nights and no fluids on his nights off. So he can alternate between 3 nights and 4 nights when he does do his distal feeding when he's supposed to. But it's clean, it's tidy, it's all in the one stoma bag, and they don't have to do anything with it. And there's a little external pump that they attach to the stoma, and it's even better than just using your oral nutritional, your 40 sips down the distal tube. It's messy with the Foley catheter and all of that. They come out and be a bit of discomfort with it. But so this is quite nice. But again, it's you just have to be practical. What do you have and what can you use? So again, this has been discussed before, the initial management, the decision is being made. You've got your dietitian in. I would dearly love if you also had a clinical pharmacist like Haidee around. But I mean, our clinical pharmacists are around on the wards, and they are really, really helpful. They're just extremely busy because they're doing a lot. they're not just dealing with these patients and they're doing a lot, but do use them. When you ring pharmacy, they're really helpful about things that you can put down, pegs, NGs. Can you crush something? Can you not? And it's just sometimes we don't think about it because they're not always with us on a round, but they are available and they are really, really helpful. The nursing role is really important, because they're monitoring their input, the output, they're looking after the patient daily, they're watching how they're getting on, they're doing patient education, they're reinforcing everything that we're saying all the time about watching their fluid restriction, or what do we call it? I think here we call it fluid allocation, so we don't we don't have a negative connotation to it. Um, and then obviously your pharmacist. Oh yeah, so this is what I asked. I asked the AI chat thing, BT, whatever it's called. I asked it, can you draw up what a nutrition support team would look like? And this is what it created for me, which I think is fabulous. I think they're all having a great time. There's a lot of them. There's fancy machines. They seem quite healthy as well. They've got their oranges and their apples, and they're all looking really happy. Someone might be on fluids at the back, I don't know. And there's ECG machines. Everything's happening. They've got your fancy Braun pumps there in the back, carry. It's just gorgeous. Well, in actual fact, I think this is probably what the nutrition support team looks like. And it's usually the dietitian who's doing most of the heavy lifting here about getting somebody home. The pharmacy really doesn't get involved in managing a patient and linking in with the different home care companies. And I am aware that the HSE has started to ask for multiple different quotes about patients coming home. Different hospitals have been asked for it across the board, and it's just adding another layer of it. So I think it's like this, and I think even the person, even the team that might be looking after the person can also feel like this as well, because they may only be one or two that they may be looking after, and they've got all their other clinical jobs to do, and it's a very, very busy, and these people do take a lot of time because they need a lot of time, and you have to have a lot of thought when you're thinking about them. And when you're running a busy job and you're not seeing a lot of them all the time, it can be really, really frustrating because you can't do what you want to do, both as the dietitian or as the physician or surgeon that's looking after them, or the NCHDs or even the nurses on the ward. I think that's where a lot of people feel like they're like that. So the most important thing, I think, is early discharge planning. I think, Karen, you probably would agree. The minute you think that this person is going on PN, you don't really think about it anymore. Just do it, because it just takes a bit of time. So early contact with your CHO, which is the financial part here in Ireland, where we have to ask, and each sort of community has a different CHO, and some CHOs are much faster at giving funding than others. And I know some of you would have been really frustrated with how that works. Ideally, it probably should be centralised, but I don't think that's going to happen anytime soon. Liaising with the home care agencies, liaising with your home care nursing, your TCP, your CIT, whoever that is, early on as well, making sure the equipment and supplies are there. I mean, nobody ever buys their home or rents their home or apartment thinking this is where my PN equipment's going to go. Isn't that great? It isn't. It's a huge volume of equipment that goes in there. You've got fridges, you've got dressing packs, you've got syringes, gloves, all sorts of things that go in there, pumps, stands, and our room ends up looking like a hospital, and that psychologically is not easy for patients or their families as well. So you kind of got to prepare them for that too. So I really think that this is something that we all miss out on. And while they're in hospital, it's not so bad because you probably will have liaison psychiatry, and they do an amazing job. Again, it's not their major role. They have to do everybody else, but they do a fantastic job. Unfortunately, we don't have a dedicated person for psychology or psychiatry, but we have an amazing psychiatrist, Professor John Cooney, who is really, really excellent. And does come and see these patients regularly, and his insights are amazing. And if you're lucky enough to have somebody like that, then that's great. But otherwise, once they get home, and if they're not from your catchment area, as Karen said, some of these patients could be coming very far away, your psychiatry department probably won't be following them up. You will have to ask the GP to get them to be done locally with the community, and that can be, take a lot of time. So I think the psychology probably has to be really thought about, and we need to get them involved earlier, and that might be, like Karen said, the medical social worker as well as psychiatrist. And then there are support groups. So there's Pint in the UK, and a lot of our patients would be linked in with them, and there is kind of like a mini Irish group, but it hasn't really taken off that much. So why do we want to optimally manage intestinal failure? Because we want to adapt them quickly. We want to get them to what the minimum amount of TPN and IV fluids that they need really to keep them well. That's sort of the way I think about it. And I'm always trying to think about, can I get this person off? Can I get this person off? How can I push this person a little bit further? Because all I'm thinking about is the complications, and I've got to think, I've got this 16 or 15-year-old, and I've got to get them to 40, 45. I've got to get them to be able to have a baby and have all those things that they are entitled to in life like everybody else. So what can I do to push it as much as I can, and how can we adapt them? And this is kind of this kind of graph is just sort of like an idea of how we would try intestinal adaptation. So you normally have your spontaneous one that's going to happen over 1 to 2 years by itself, but then we kind of want to try and accelerate it, or use hyper accelerated adaptation is what we call it. That's where I think the tetraglutide comes in. But there's a lot of debate about that. I think people would prefer to hold off the tetraglutide until you've had spontaneous adaptation and then use it, whereas I think we probably should use it a little bit earlier and push adaptation faster, because the benefits of rehabilitation are, tenfold really when you think about it. Reducing your time on PN, reducing your time means reducing time for them, which means more time with their family. They can eat, going out. All of these things are really important. And it also protects their gut and protects their liver and their bones and their kidneys going forward. So these really are the big complications and consequences of PN that we talk about. And I've highlighted the big four really, but every single one of them is important. So the catheter-related complications are significant. The liver is the other one that we probably worry about, renal and skeletal. I probably won't be talking that much about renal today. I was just going to concentrate on catheter-related and sepsis, and bone and liver, and what we should be doing for those. But as you can see, there's a massive impact both neurologically, on the gut as well, psychologically, and there's metabolic, as well as issues with the immune system too. So complications and consequences are not insignificant, and it's our job to try and limit these as much as possible and prevent the evolution of these. So there is a multidisciplinary role. So we need the dietetics services, the home nurses services, and the physicians. So everybody needs to be linking in when these patients go home to try and see if we can manage their long-term care on HPN. And we've got to try and think about, these are the ones that I think about when we're managing complications. We're thinking about infection control, we're thinking about liver, and we're thinking about electrolytes. So what we want to do we want to try and reduce the risk of catheter-related bloodstream infections and catheter-related complications, because if these patients are going to be on long-term PN, access is really, really important. And access is really important to them as well. So we've got to try and reduce the risk of that. Liver, we need to constantly be monitoring for signs of intestinal failure associated liver disease. And the dietitians and physicians may be adjusting formulations and medications to reduce the risk of cholestasis and adding things in to try and prevent that. Electrolytes as well, we're always going to monitor for metabolic complications, because it's very important. Your vitamin D, your magnesium, all of those things will run into metabolic bone issues as well. So the long-term follow-up, there are ESPN guidelines that were in 2016 and 2020, and it suggests that there's a multidisciplinary review, ensuring that there's good collaboration between everybody, but not everybody has that. We don't all have access to the home care team, the dietetic services, the pharmacists and physicians all the time. But when these patients come in, it's just worth thinking about other things from long-term. It's not just about their TPN. So even if you can, when they're coming in, to try and see them maybe when they're coming in with the physician as well, that you drop down to, that they're not seeing you as a dietetic person, separately, but to try and see, and if you can, come in with them when they're there in the clinic and sort of trigger these kind of things that people should be thinking about when they're seeing the patient. And it's not just, oh, your blood's fine, off you go. It's a little bit more than that. And then I think it's really important to continue to monitor the quality of life. Now, this is something I don't think we've been doing very well, but now we've got this Salford, we're using the Salford Quality of Life questionnaire, and I think it's really important that we focus on this, because we need to focus on what the patient wants. And this is a lovely study actually that Karen and Mary McKiernan did in the Matter, which was looking at your compliance with the 2016-2020 ESPN guidelines. And it's really interesting. The majority of it was like, you're incredibly compliant, and I would say most of the people across the board probably are. But there are things where we're not compliant, and that is the nutrition support team and the multidisciplinary team, and probably bone health a little bit, and then maybe how we manage catheters and catheter line salvage and things like that. I think across the board that would probably be the same. And this is nice because this shows the quality indicators. This is from gastroenterology, and it's a little idea of what we would think of the quality indicators and how we would manage patients both on enteral and parenteral nutrition. So one of the things that they were suggesting is that, you know, we want to look at the rate of readmissions, patient's quality of life and infection and what those risks are, catheter related infections. But what's interesting is what do patients want? And this is a really nice study. And I haven't got my glasses, so I'll have to see. I think it's, oh yeah, Dressen. Yeah. So this is a really nice study where they actually asked not just the physicians what they thought the outcomes should be, but also the patients. And the funny thing is, we don't disagree that much. Patients are really concerned about their catheter and their access. We're really concerned about their catheter and their access. They're also their quality of life and their independence. Where things were a little bit different is some of the physicians, it didn't seem were as worried about survival as much as the patients were. But and this was across 9 different intestinal failure units right across the world. So it was New Zealand and Australia, America, and Europe. And it's interesting because we, you know, sometimes you wonder, do we really want the same things? And we do. And I just thought now we'll just focus again just on these 3 topics. So catheter-related complications. So who's at risk? So this is a really nice study by Braun. And the beauty of this study, this is a Danish study. And the Danes have had an intestinal failure registry for over 40 years. Which is phenomenal, which means they can pull data out of everything really and anything that they need. And they had a look at their patients over 40 years. And for the first 3 decades, their catheter-related complications risks were quite low. And then they saw a spike in the 20s from the 2000s until now. And they think that that's because patients are a little bit older, patients are surviving catastrophic events like Karen's patient that, you know, probably 15, 20 years ago may not have survived that catastrophic event. It just worked very, very quickly, and she's a really good center. So a lot of that is probably down to that. Interestingly, one of the things is pathophysiology is really important. So that's why I was saying that sometimes the underlying condition of what brought them onto PN is equally as important as why they're, you know, as the length of time that they're on PN. So patients who have dysmotility disorders are 39% more likely to experience a catheter-related complication than somebody who's got a mucosal disease. The other thing that was interesting, and I know there's community nurses in the house. But actually, having a community nurse administer your HPN was considered a higher risk. Yeah. Now, I think, and so did the Danish team, that when they look at that, it's because in Denmark, like in Ireland, which is different to the UK, all our home care PN is provided by the family members, really, usually, or by the patient themselves. We don't have home care nurses. We don't have the funding. It's not possible for us to get somebody to fund to come and disconnect and connect. We have to make a huge case about having somebody to fund and connect and disconnect with the HSE and a load of big business cases to be put in. And normally it's because somebody has been admitted multiple times with complications or issues, and you have to make a point or prove financially that it'd be much cheaper for them to have somebody to connect and disconnect. And this, I think, is only because, same in Denmark. So these patients are the most frail and probably the most difficult patients to manage. So that's why I think that there's a spike there. So and then prior, obviously, catheter-related complications, and if you've had a catheter-related infection more than twice, will be more of the risk of having a catheter-related infection. And this is another study now, and this is by RCSI and all. And again, it's looking at who's at risk from catheter-related bloodstream infections. So duration of PN is a big thing, how long you've been on PN, prior catheter related, and again, community connections and disconnections. But again, this is from a centre where you only send out the community nurse to connect and disconnect because you have a problem. So I don't think that's necessarily a mark per se. It's more a mark of the individual that you're getting connected and disconnected this way. Predictive factors associated with complications: length of time on PN, catheter location, the type of catheter you put in. So it's really important to liaise with the vascular team and the team that are going to go down, and the IOR team, the interventional radiology team, to put in a catheter. You want a single lumen catheter. Now, I know there was a major issue with availability of single lumen catheters here after COVID. I think there was some issue in making them in the factory. So there was only double and triple lumens, because obviously a majority of these are being used for chemotherapy agents and chemotherapy patients. So they're not going to just make single lumens. If they can't, they're going to go with double and triple lumens. So a lot of patients will have double lumens in, and maybe even there was a patient who came back and she had a triple lumen Hickman in. I nearly lost my life, because I knew that that catheter was going to go eventually, and eventually it did, because the diameter of the catheters are much lower. So I think it's really important that when this person or a person is going home, just to liaise with making sure the type of line that goes in is a good line, and the location is the good location for a long line catheter. So the type of catheter used, whether it's a single or a double, and the diameter of the catheter is really important. Then whether or not you're using tower lock or not. And then the risk of thrombosis is usually the time on HPN and the number of infections. They're really the big ones and the big hitters. Line salvage, I think it's important to emphasize that yes, we can be aggressive with trying to salvage lines, but you should never compromise patient safety. So you have to be sensible about what you want to do. There is data to support salvage in Staph aureus associated catheter-related bloodstream infections that occur in a high proportion of patients. Impaired treatment with CVC locks, systemic antimicrobials, using a peripheral catheter or a PICC while you're waiting for to clear that Hickman, and linking in with microbiology. I work in James's, so I have a fantastic team of infectious disease consultants and clinical microbiologists. I mean, they're just amazing. I don't know how come they don't run when they see me, because normally these patients will have really odd bugs in their lines, but they're just phenomenal. And then they will also help with community assisted home IV antibiotics as well for these patients. So there's a good chance that you can salvage and to try. You'll always need gram-negative and gram-positive cover, really. Salvage should never be attempted if there's septic shock, if there's a damage at all to the catheter, if there's any idea that there is distal infection at all, a persistent infection after another treatment already, if you've already tried salvage and they're back again within a few weeks. I don't think you should try and salvage that line again. Pseudomonas and fungal infections are a definite no-no for trying to salvage. How do we prevent them? Well, obviously we have to teach the patients the aseptic techniques, and we have to kind of re-educate them every so often, especially if they come into hospital, regular monitoring for them, use of antibiotic locks and dressings if we need to, chlorhexidine. I love the barrier caps. Now, they're not available when a patient comes into the hospital, but I will be really cross if they come into the hospital and they're in and they don't have their green caps, and I'm like, where are your green caps? So please bring in your green caps. So I think it's just as important as everything. Training again and retraining, use of the single line, and reducing your infusion risks and rates if you can. And sometimes you might need to watch. Sometimes some patients will need some sort of anticoagulation. It's if they've had a risk of DVT. In Crumlin, they would always have the pediatric patients on a low dose of warfarin. And it used to be standard practice with all intestinal failure units that patients would be on a low dose of warfarin, but the data has suggested that that doesn't really prevent. It would only prevent if somebody is at risk of a thrombosis rather than everybody being on it. So I just thought we might just mention sepsis here as well. It's a leading cause of death in anybody with acute intestinal failure. 1.7 to 15% of deaths result in a catheter-related bloodstream infection. You've got loss of your GI function, you've got malnutrition, you get atrophy of the gut and the mucosa, which makes it more permeable. You get changes in your microbiome, makes it easier for guts to translocate. You have increased insulin resistance, protein catabolism, and you get a load of cytokine storms. But the thing is, a lot of these patients will not manifest a really systemic effect. So you just have to be very cautious. So about 50% of them won't have a raised white cell, and about 50% of them will be apyrexial. So you really have to think about it. So if you see a CRP that's going up, if I see any suggestion that a CRP is going up, I bring them in for blood cultures automatically straight away. and you have to have a high index of suspicion. The albumin maybe might be falling, there might be a slight change in their liver blood tests. They may not be systemically unwell, but you need to think about it. And you need to think about distal metastatic disease as well. Because we've had patients with paraspinal infection from an undetected line infection, and all they kept complaining about was chest pain. They had CTPAs, they had CT abdomen pelvis, nothing was picked up until they actually had a fall and got an MRI. And the MRI picked up the lesion. So, it's just important to just be thinking about everything else. You've got osteomyelitis and things like that. If they've got bones or hip joint replaced, that's places for it to go. So metabolic complications, I think we'll just move on to now as well. So you've got to watch their electrolytes. You've got to adjust your PN formula. That's where your dietitian comes in. You're looking at your glucose and trying to monitor and manage liver disease. So what you want to do is you want to limit your glucose and your lipid overload. You want to regularly monitor the liver enzymes to reduce the stress on the liver. And again, infections will also put stress on the liver. So you want to try and manage that as well. So intestinal failure associated liver disease, it's liver injury attributable to intestinal failure. It's PN related, but not limited to the PN. I think that's really important to say, because before this used to be called PN related liver disease or PN associated liver disease, and everybody thought it was the PN that was causing the trouble, but it actually really isn't when you look at it. And then there's a lot of patients who may have had underlying liver disease that mightn't have been offered PN because they were afraid that perhaps they might develop cirrhosis quickly. So it really is, it's occurring in the absence of another primary parenchymal pathology, such like a viral or a metabolic or an autoimmune hepatitis. There are other hepatotoxic drugs and factors that are involved, alcohol, medication, and then you'll also have things like biliary obstruction that cause problem. It's frequent in infants, obviously, and they tend to get more cholestasis, whereas older children and adults tend to develop steatosis. There's no actual, clinical guidelines per se to say to look for, or no kind of calculator per se, but what we do is we look at their liver blood tests radiologically, look at ultrasounds, and then sometimes when required we would do ultrasounds. The diagnosis is clinical and biochemical and radiological. There's no formal agreed criteria, and prevention and treatment is really trying to treat aggressively as much as you can underlying liver disease that the person might have, and then just trying to prevent ongoing liver disease as the person may have predisposing factors that they may evolve into an IFLAD. So this is really nice. It looks at the pathogenesis really of liver disease, and it's multifactorial. So the top, I don't know whether it projects, you get it really that well, but the top is looking at the PN factors and the bottom is looking at the gut factors really. So the main things really obviously are, if they're fasting, you're going to have problems because you're going to have a change in the enterohepatic circulation. You're going to have a change in your bile salt and and how your bile salts are absorbed, and all of this results in changes to gut motility, gut permeability. You get cytokines formed, and it's a very complex pathway, but it eventually leads to steatosis. And then you add on top of that, obviously, the factors of having PN and the risks of all that Karen and Haidee had discussed, and how we try to manage that, also contributing to the pathogenesis of the intestinal failure liver disease. So it's really a combination of factors that result in it, and that's what we kind of have to be watching for all the time. And then if you look at this is the prevalence and incidence of liver disease through across a meta-analysis, and they looked at it when each one of these groups was looking at it a different way. They might have been looking at the AST-ALT ratio or the AST to platelet ratio, but when they looked at it, the prevalence of cholestasis in their chronic intestinal failure patients was 5 to 15%, and then steatosis was 19 to 46%, and fibrosis was 11 to 22%, and then other was considered 7 to 40%. So quite a significant burden of our patients can have IF-associated liver disease. And these are kind of also looking at the different risks of why you might get it. And again, it just splits it into the PN and the change in the gut from having chronic intestinal failure. So what we want to do is we want to prevent the development, and because we want to time a referral if a patient needs to go for transplant. So one of the big factors for sending somebody for intestinal transplant assessment is if they are developing cirrhosis or developing a liver disease, because ideally the intestinal transplant team would prefer to do a transplant without having to add in the burden of a liver. So it's all about the timing of that. So routine assessment liver function tests probably every 3 to 4 months. We would look, I suppose there's a panel of experts looking at different ways of how we can, what criteria we should use. But abdominal ultrasound and liver function tests are probably part of the big one. And FibroScan obviously is very trendy now for using in our obesity patients. It hasn't really been found to be significantly correlated with adult patients with chronic intestinal failure, which is a pity because it's non-invasive. And a lot of these patients are very, very vulnerable. And I often think, oh, I'd like to do a liver biopsy, but actually, no, I wouldn't. Because I don't know what the consequences might be. You're bringing somebody in, and doing a liver biopsy. Because they are really vulnerable. So it's quite difficult sometimes to do the timing. But liver histology really does remain the gold standard of looking at intestinal failure associated liver disease. Now, I know in Leuven, they actually are using FibroScans to monitor their patients on tetraglutide, which I think is interesting. It'll be interesting to see what comes out of that. I haven't sent any of our patients over yet for FibroScan, but I probably will. And then another thing, I suppose, looking at the bowel and things like that would be intestinal ultrasound and looking at bowels in different ways for sort of non-invasive ways of monitoring. So this is sort of the nutritional deficits, which Karen has sort of talked a little bit about as well. So your vitamin and mineral imbalances and your essential fatty acid deficiencies. But the big thing here is really all of those key in here into the prevention of bone disease. And the big thing in this paper that looked at intestinal failure related patients with osteopenia and osteoporosis is actually their BMI. So that is really, it still is the BMI, and it is a big risk factor anyway when you've got osteoporosis and osteopenia. It's the risk of BMI. So the BMI and their vitamin D. So they're the ones that we need to be thinking about that are at risk of developing bone disease. So we should do bone metabolism monitoring. We should assess the bone density with the DEXA scan, and at least initially I try to do it on everybody who starts. So everybody who's starting on TPN, I will, once they're discharged and out as an outpatient, I will do a DEXA bone scan on them. When all the pediatric patients come over, even though they're very young, I will actually do a DEXA bone scan on them because a lot of them will have osteopenia actually. Supplementing your calcium and your vitamin D when needed, and then that might be liaising with your pharmacist and your dietitian about how you want to do that, because some of these patients mightn't be able to absorb it, so you might need to go to IM. So I'd be really interested in your oral dispersible calcium and vitamin D to see how that pans out. Management of osteoporosis, early use of bisphosphonates and bone protective agents. I refer all of the patients to the bone health team in St. James's. That's run by the Medicine for the Elderly, and they give fantastic outpatient follow-up with them. So all of them, the minute that I see there's an osteomalacia and osteopenia, irrespective of how old the patient is, the patient goes straight to the bone health team for referral. Long-term use of the intravenous lipid emulsions sometimes increase the risk of bone risk. The other thing we have in St. James's, Kira and Ivana spoke to, and Jane, who's our fellow, spoke with the physiotherapist, and they developed a leaflet physiotherapy, because I think it's really important. They don't have to do much, they don't have to go to the gym, but it really does help to help prevent bone disease if they're doing some sort of muscle strengthening exercises. So she developed a leaflet for us. She said that she would do a video, but she said nobody ever goes online to look at them. And she said people still like leaflets. Now, I'm not sure, but she says so. Anyway, we give it to all our patients, and I don't know whether they really do it or not, but anyone can, if anybody wants it for their department or anything like that, just email myself or Kira, and we'll send it on to you, because I think it's really important. Every time they come into clinic, we talk about it all the time. So you have to assess for generic, so as well as intestinal failure specific patient factors, which are going to contribute to a low bone mineral density. So age, gender, menopausal status, parenteral history, what they're on, type 2 diabetes, hyperparathyroid, looking for other factors. Do they smoke? Do they drink? Are they doing weight-bearing exercises? Are they, getting enough sunlight? Are they getting out? Our patients don't often. What other things could they be on? So this again harks back to, what was the underlying pathophysiology that drove this patient to end up being on PN? Are they exposed to corticosteroids? Are they on long-term PPIs? Are they on any heparin containing medications? And then this is from the BIFA statement about how to investigate patients and manage them with chronic intestinal failure for bone metabolism. So undertake the risk score, which is the fracture risk assessment, which is a calculator, which is a series of questions that sort of identifies your risk of developing a fracture. Using a DEXA bone scan. A lot of these patients will have had CTs or MRIs. Sometimes they can be interpreted by a radiologist. Very often our radiologists will be able to, there's a special computer algorithm you can put it in that can actually look at what their bone density is, but also what their muscle density is. Which is really important. Sarcopenia is also equally important here. 3 months electrolytes, doing serum calcium, magnesium, and phosphate, and at 6 months doing their vitamin D and their PTH. I think again it's really important, just as I'm coming to the end of this, I think, to talk about psychology and quality of life. I think it's important long term for their carers and for them. Make sure that they've got mental health supports. Make sure you're doing your quality of life. Talking to and ask them, the clinics, obviously these are complex and intense patients with very difficult and heterogeneous populations, so a lot of them have different needs. So they may be a Crohn's patient, they may be a radiation patient, so there may be or they may be a chronic intestinal pseudo-obstruction, so they may have a lot of symptoms. So you may not get the chance to talk about this, but I think it is important to try and address it in clinic or every second clinic visit to talk about the psychology and the quality of life. Long-term follow-up again needs multidisciplinary, and you need to focus on the patient safety. That's educating the patient, keeping them up to date, reinforcing things, so talking about their oral health as well. So what are they doing to manage all these sweet things that we give them and these salty things like their St. Mark's and their 40 sips? Are they going to the dentist? Are they using a high fluoride toothpaste? Are you doing your physiotherapy? Are you getting your exercise? Are you going out? How are you managing? How whoever is connecting you and disconnecting, managing you. So all those things need to be managed, as well as all the other complications. Making this clinic sound terrible, don't I? But if we had the nutrition team that the AI person generated, it'd be easy, wouldn't it? So really, in conclusion, these patients do require specialist management long term. It does need a multidisciplinary approach, and I think we are really lacking in that here. Effective long-term management complications involves a really close collaboration with healthcare providers. So you'll see I have sent patients to the bone health team, I've sent them to the ID team, I've sent them to psychology and psychiatry. If I can't get it done locally in my hospital, I will ask the GP to send it locally. If they've got other symptoms that are going on, they often will have gynae symptoms. A lot of the females may have some gynae symptoms as well, especially as they're moving into the menopause and things like that. So be aggressive. Ask for help, send them to the right person, send them to endocrine, send them to where you need to send them to try and get. If you can't get the multidisciplinary people into you, then try and just link in with somebody. There will always be somebody in your hospital who's interested and will be approached and will be willing to talk to you about these patients. You've got to kind of identify and intervene to minimise the risks and optimise the patient's quality of life. In Ireland, in the Republic, we still have patients dispersed across a large number of non-specialist hospitals and acute hospitals that are not really getting the care that they need. There's still inequality of access to specialist care here. I think it's an under-resourced dietetic service and multidisciplinary structure, both in the hospitals and in the community. So hopefully things will change in time, and we'll keep pushing with the HSE, and we'll see how we go. So thank you so much for your time, and I'm happy to take any questions.